Hello and welcome. Today we're diving into a complex and potentially life-threatening condition affecting the urinary system, thrombotic microangiopathy, or TMA. This is a disorder that affects small blood vessels throughout the body, including those in the kidneys, leading to significant complications. Join us as we explore the causes, symptoms, diagnosis, and treatment of TMA. So, what causes this condition? TMA isn't a single disease, it's more of a syndrome with various underlying causes. Some of the primary culprits include genetic mutations, particularly those affecting the complement system, a part of the immune system that helps fight off infections. Certain infections, such as those caused by E. coli producing Shiga toxin, can trigger TMA, especially in children. Medications like some chemotherapeutic agents and immunosuppressants can also damage the small blood vessels and lead to TMA. Autoimmune disorders, such as systemic lupus erythematosus and even pregnancy, particularly in the form of HELP syndrome, hemolysis, elevated liver enzymes, and low platelet count, are also known risk factors. Let's talk about the science behind TMA. The key feature is damage to the endothelial cells, the cells that line the small blood vessels. This damage activates the coagulation cascade, leading to the formation of tiny blood clots called thrombi within these vessels. These clots obstruct blood flow, damaging organs like the kidneys. The reduced blood flow also causes red blood cells to be fragmented as they squeeze through the narrowed vessels, creating what are called schistocytes. At the same time, platelets, essential for blood clotting, are consumed in forming these thrombi, leading to thrombocytopenia, a low platelet count. The overall effect is a vicious cycle of vessel damage, clot formation, and organ damage. While TMA itself is relatively rare, its incidence varies depending on the underlying cause. Shiga toxin-producing E. coli-associated TMA is more common in children, particularly during outbreaks of foodborne illness. A typical hemolytic uremic syndrome, often caused by genetic complement abnormalities, has a lower incidence. HELP syndrome related to pregnancy is dependent on the prevalence of preeclampsia. Certain geographical regions may see higher rates of specific TMA subtypes due to differences in genetic predispositions or environmental exposures. The symptoms of TMA can be quite varied depending on the severity and organs affected. Common signs and symptoms include fatigue, paleness due to anemia, bruising easily, or prolonged bleeding from minor cuts due to low platelets. Kidney involvement can manifest as decreased urine output, swelling in the legs and ankles, and high blood pressure. Neurological symptoms can also occur, such as confusion, seizures, and even stroke in severe cases. Abdominal pain, nausea, and vomiting are also frequently reported, especially in Shiga toxin-associated TMA. Diagnosing TMA involves a combination of blood tests, urine tests, and sometimes kidney biopsies. Blood tests will show anemia, often with the presence of schistocytes. Platelet counts will be low, confirming thrombocytopenia. Kidney function tests, such as creatinine and BN levels, will be elevated if the kidneys are significantly affected. Specialized tests, such as complement assays or Shiga toxin testing, are needed to identify the underlying cause. A kidney biopsy can provide definitive evidence of TMA and help differentiate between different types. TMA isn't just one thing, it's a group of disorders. We can broadly classify it into two main categories. The first is thrombotic thrombocytopenic purpura, or TTP. This is often caused by a deficiency in the AMTS13 enzyme, which breaks down a protein called von Willebrand factor. Without enough AMTS13, von Willebrand factor builds up, causing excessive platelet aggregation and thrombus formation. The second major category is hemolytic uremic syndrome, or HUS. HACE can be further divided into Shiga toxin-associated US, often linked to E. coli infections, and a typical HUS frequently due to genetic abnormalities affecting the complement system. Treatment for TMA depends heavily on the underlying cause. For TTP, plasma exchange is the cornerstone of treatment. This involves removing the patient's plasma, which contains the deficient AMTS30 enzyme or antibodies against it, and replacing it with donor plasma. For Shiga toxin-associated HUS, treatment is primarily supportive, focusing on managing kidney failure with dialysis and addressing any complications. A typical HUS often requires treatment with complement inhibitors, such as eculizumab or ravulizumab, which block the activation of the complement system. In all cases, managing blood pressure and addressing any neurological complications are also crucial. Preventing TMA largely depends on avoiding the underlying causes. Practicing good hygiene, especially when handling food, can help prevent Shiga toxin-producing E. coli infections. Ensuring adequate cooking temperatures for meat can also minimize risk. For those with known genetic predispositions to a typical HUS, proactive monitoring and early intervention may be necessary. Avoiding unnecessary medications known to trigger TMA can also be beneficial. Careful management of autoimmune disorders can also reduce the risk of developing TMA. The prognosis for TMA varies significantly depending on the underlying cause, the severity of the disease, and the timeliness of treatment. With prompt diagnosis and appropriate treatment, many patients can recover fully. However, some individuals may develop chronic kidney disease or other long-term complications. Recent research is focused on developing more targeted therapies for different subtypes of TMA, including new complement inhibitors and ADAB-MTS3 replacement therapies. These advances offer hope for improved outcomes for patients with this challenging condition. Thank you for joining us on this exploration of thrombotic microangiopathy.